Hi, my name's Olivia. I'm a fourth year pharmacy student currently in my APPE rotations, and I thought it would be fun if I shared some of my topic discussions that I've been doing, mainly because I thought mine looked really cute. I love pink, and I thought other people might want to learn in a cute way too, because I know it helps me if I have something cute to look at. So my first topic I'm going to be talking about is hyperkalemia. That can be caused by several different things. Some offending medications that could cause this: Bactrim, NSAIDs, lithium, ACE and ARBs, spironolactone. A typical disease state that can cause it is like having kidney function failure, because we just can't excrete things as well. It would also have many other electrolyte imbalances. And then stress on the body, so things that can cause cells to burst, like trauma or chemotherapy. And then from a lab standpoint, K5 to 5.5, typically mild, asymptomatic, and then getting to 6.5 to 7 is usually symptomatic. Some of the symptoms being heart palpitations, muscle weakness or numbness, nausea, vomiting, abdominal pain, arrhythmia, diarrhea, chest pain. And then the treatment, so first we have to stabilize the membrane because we're trying to get the K back into the cells from the bloodstream. So if we don't stabilize the membrane, it's not going to get back in there and be able to stay there. So we first got to do that. And we do that by using calcium gluconate, 1 gram. And then calcium gluconate is preferred over calcium chloride due to injection site reactions. And then next, after the membrane is stable, we can get the K back in there. We can use insulin, usually aspart or short acting. It brings glucose back into cells, which also brings K into cells. And then depends on the hospital. It's 1 unit per kg or like flat 10 units, depending on protocols. And then you want to give that with dextrose to prevent hypoglycemia, because typically people don't have high blood sugar at the same time, so you just don't want to go too low. And then albuterol can be another agent that can be used for the distribution phase. And then for elimination, we've got a couple different options. The one I've been seeing a lot on my hospital rotation right now is Lokelma. That's pretty common. That's a more slower acting one. So it's just binding to the potassium and then it's getting excreted out through the colon. So there's packets with that. So usually like if we see like a potassium in the 5 to 5.5 range, they'll just give like a 5 or 10 milligram packet for 1 dose and then recheck the labs the next day or later on in the day and then go from there on whether they want to give more. And then hemodialysis is another way to excrete it. It's going to excrete it right from the blood. And then sometimes I've seen like people that are on hemodialysis long term, like they'll get their hemodialysis and then on the days they don't, they will use Lokelma as well because they're going to have chronically high potassium because their kidneys aren't working as well. And then a faster excretion mechanism is furosemide, the loop diuretic. It's just going to get it out through your urine. So that's a faster way to do it. Like if they're having like hyperkalemia emergently and you need to like start doing like calcium, insulin, furosemide. And then another thing that I just really haven't seen in the hospital, I haven't been there that long, but sodium bicarbonate, it also helps alkalize the urine and then enhances excretion of potassium that way as well. Thank you guys so much for listening. I think I'm going to be doing this weekly or so with my topic discussions I've done at the hospital. So hopefully you guys like it. Please let me know if you have questions or anything in the comments. Thank you so much. Bye-bye.